Good day, everybody. I am Bradley Meltson, and I have my co-host,
Tom Davies.
Tom Davies. And then you are in store for Farmland episode 13. Basically, we're going to continue on something that keeps on being the billion-dollar buzz that keeps on growing, and we can't stop talking about it. And yes, that is, we're going to be talking about GLP-1s today. It's been hard to believe. Our very first, I believe, Farmland was actually on this topic, right, Tom?
Yes, very early podcast was discussion on the impact of GLP-1s for sure, right?
Yeah, and
So we are, what I've been asked recently when having conversations with external parties is, well, what's the next big thing? And I'm just like, well, hey, let's pump our brakes a little bit because I don't feel that we've crested the wave with regards to GLP-1s. So let's just revisit GLP-1s and what does it look like moving forward?
Exactly. And as always, just as a reminder, Farmland is here to serve up the freshest pharmacy information and insights to benefit advisors, employers, and pretty much anyone else looking for a better understanding of the industry. And we'll take the biggest topics, dig deep, offering perspectives you won't find anywhere else. And as always, Farmland is brought to you by RX Benefits. So, Tom, let's keep starting with that original question. I'm sure everybody in the universe has no clue what a GLP-1 happens to be, but why do they still matter? Why are we still talking about this, man?
Yeah, you're right. I don't think there's a lack of acknowledgement with regards to GLP-1s. It's really been the ongoing interest associated with GLP-1s, and there's some driving factors with regards to some of the growth we've seen overall in increased utilization rates. Right, it's provider level of comfort with regards to accessing these medications. We've had GLP-1s within the marketplace for what, 20 years now?
It's been a while.
Exenatide was the first approved GLP-1 in 2005 or so. And then we actually had our first approved GLP-1 for weight loss in 2014. I don't remember spending much time on GLP-1s in, 2010 to 2020, but we did see a significant increase in interest around GLP-1 starting in the 2021, 2022, 2023. And like I said, there's been some factors that contributed to that: prescriber comfortability, just social media presence associated with these medications, and then the robust nature of their efficacy, right, with regards to either you're utilizing to treat type 2 diabetes, when we're seeing pretty significant reduction in A1C that rival what we've seen with insulin in the past, or the reduction in weight loss, where we're seeing anywhere from, with the newer agents, anywhere from 15 to 20% reduction in overall weight associated with utilizing these drugs. So those are some of the factors that are increasing utilization. And then updated guidelines, where we're looking at 90% of the type 2 diabetics are likely candidates for a GLP-1. So all of these are really contributing to the interest of GLP-1s. And like I said, the fact that we really haven't crested the wave yet, because we're still seeing an increase in utilization month over month, year over year, and I don't think that we're likely to see a reduction or a plateaued effect for several years to come.
And let's talk about what you just mentioned here. Is there's not a plateau because you have a pent up demand, people that have the potential to access these medications, right? And just to kind of and you talk about the effectiveness of these, which lots of people want to be on these medications for the effectiveness, either to control their diabetes or to potentially lose weight. But let's put it into the dollar perspective. So we basically went, this time last year, roughly 2 million prescriptions were filled last December, in December 24. And in December 23, it was about 500,000 GLP-1 prescriptions. So that's a heck of a growth rate that you've just indicated. It's poised for even more growth rate. And when you look at the dollars associated with it, I believe the market share is projected to be up to $470 billion within the next 7 years. So it's very costly. But there's some other things going on in this particular marketplace that you mentioned a moment ago. It's not just being looked at for diabetes and weight loss anymore either, right? So there's a lot of things that have potential to drive that demand. And so,
Right.
can we talk a little bit about how those new indications might be a little bit more something we just need to talk about on the horizon? Is there some things that
Yeah.
you can share about that?
Yeah, I think that I'm a numbers guy as long as I don't have to calculate the numbers, truth be told, right? So I've looked
Yeah.
a little bit about what the market share is, and you brought up a very good point that right now we're at about $47 billion with regards
Mhm.
to GLP-1s throughout the world, the utilization, and by 2032 we're looking to about a tenfold increase, so 471 billion. Of that, the U.S. market, which accounts for 5% of the world's population, is about 75% of the total market share with regards to GLP-1. So we're accounting for about 33 billion of that 47
We're
billion.
number one.
Um, yes, we're number one, and I don't see that there'll be uh, less of an impact in the U.S. population moving forward. So we're likely to still to remain right in that 70% of that $471 billion by 2032. And I like to look at, well, how do you compare this to other drugs within the class? And the first one that came to mind was SGLT2s, right? Right now, they account for about $5 billion within the U.S. market
Yeah.
share,
And for
right?
reference to our audience, an SGLT2, an example would be like Farxiga or Jardiance, the dancing commercials that you see on television. Yeah.
Appreciate that. So
Just
an oral alternative, right? Pretty similar A1C reduction, do not have the impact on weight, right? So they account for about 5 billion. They're about half the cost. So even if you doubled the cost, right, to make them more equivalent to the cost of GLP-1s, GLP-1s are still a 3-to-1 ratio with regards to overall revenue
wow.
impact in the U.S. So I like to put that within reference, right? And we've seen that reflected in the utilization rates. There was a study that was done, a survey that was done early in 2024 that stated 12% of the U.S. adults have at least tried a GLP-1. So that's 1 in 8 people. So anybody that has a large family like me, I know at least 2 people in my family that have actually tried a GLP-1. I think that's a pretty astounding number, right? So if we think U.S. adults, 12% of that, it's about 30 to 35 million U.S. adults have at least tried a GLP-1. That's a large number of patients trying a GLP-1s. That's a large number of prescriptions.
So how many of
But
them would you say
that's
can
just
access
based
those
on where
meds?
we're at today, right? So we're
Yeah.
looking at GLP-1s that do have indications. That the two main indications that are driving utilization today or diabetes, which is about 75% of overall prescriptions. And then the other is the weight management piece, right? So we're looking at about 20% of the overall prescriptions. But with the label expansion, with MASH, the utilization for kidney protection, all of this is going to lead to the potential for increased utilization within these particular medications. But you brought up some other pending um, research and developments that's being done for other indications. And what are some of those indications?
Well, I mean, I've kind of looked at the market, and I know Alzheimer's happens to be one of those indications. I believe uh, a really interesting one coming up is more for dependencies, like kind of like alcoholic dependency or drug dependency as a method to reduce cravings associated with,
Hmm.
let's say, drug use. Um, I find that extremely interesting only for this reason. The the mechanism of action for a GLP-1 does hit the brain, the central nervous system, and there is a potential what we call a dopamine response, right? And whenever you have a dopamine response, that is your pleasure center. It's where your cravings are going. So there's an ability to suppress that area. Um, well, that could lead to an entirely different avenue of how these drugs can be explored. To me, the most interesting piece is someone that has an interest in drug misuse and abuse. and that type of area. And I've been on committees in the past in my particular state on that topic, particularly during the opioid epidemic. I find it really interesting that a lot of times these medications used to potentially detox or help people wean off are often what people get hooked on. So I love to see how the manufacturers will eventually skirt around the physical and psychological dependencies of these medications in the future, because I think a lot of people are physically and psychologically dependent on them now. But that's just that one to me is the interesting one. In addition to, of course, your standard chronic kidney disease, heart failure as being your
Osteoarthritis.
osteoarthritis. I've heard rumors of it. Um, Also in psoriasis. I've heard it.
Psoriasis, yeah, I think that the work that's being done in psoriasis is interesting, right? I think
Yes,
there's been some publications out there of the utilization of GLP-1s, monotherapy, and the potential impact on psoriasis, because we know one of the drivers with regard to psoriasis is, or the risk factor is obesity, right?
correct.
Adipose cells, adipocytes, they release these cytokines, tumor necrosis factor, interleukins that we use these biologic therapies to block. So there's been some interesting study that you either use GLP-1s as a monotherapy and the weight loss contributes to less severe plaque psoriasis, or you use them in combination with one of the biologic agents, and we're seeing if used in combination, you're having a higher percent of the population having resolution of plaque psoriasis, which is interesting. Now, these are very small studies, right, in plaque psoriasis. I think for me, as I look at some of the pending approvals and what's being studied, I kind of look at kind of the population that could be impacted. And I think the one that gives me the potential for most angst, just based on the large cohort that it could be applicable to, is the utilization in prediabetes.
Oh,
So it's
absolutely.
about 3 times the number of patients that we have diagnosed with type 2 diabetes. So you go from about 30 million or so, approximately, so just under 100 million with prediabetes. That's a very large patient cohort that potentially could qualify for the utilization of GLP-1.
So, are there any ongoing studies right now that are focused on prediabetes, or is the primary more of a um, kind of a cohort review of people that are on it for weight loss or other reasons, that they're looking at them in a pre-diabetic state to see how things are working to prevent them from moving to diabetes?
There's additional research that needs to be done, but there has been some preliminary trials that have gone all the way through the trial process, right, to evaluate the utilization of GLP-1s in patients with prediabetes. And what they're seeing is either a decrease in the risk of developing type 2 diabetes, or the increase in normal glycemic patients with the utilization of GLP-1s. So there's some early study with prediabetes. I think it's more of a proof of concept. So I think there's likely to be continued research and development in prediabetes. If I'm a manufacturer, I'm gonna really push
Jump
on
on that.
this as a potential, because I realize my population is very large. So I think the prediabetes cohort and research and develop is one that we definitely need to keep our eye on.
Agree, and I think there's a lot of potential avenues for the manufacturers coming here, but I think there's a lot of pushback, right? So we do have some pushback with employer groups in terms of the spending. There's a little bit of pushback on, depending on the administration that happens to be in office, on whether or not to consider Medicare, Medicaid coverage versus not
Hmm.
for a lot of these medications, particularly on the weight loss side of things. But what I find extremely interesting is that the mechanism of action of these medications are geared and cause weight loss. They do have some anti-inflammatory reducing effects, but at the end of the day, it's a lack of intake of calories that ultimately lead to this, right? I mean, at the end of the day, that's what you're doing is caloric restriction using a medication as an assistance, right? Medication assisted caloric a reduction mechanism. Yeah, that's a lot of words I just made up in
Hmm.
just for the sake of seeming like I'm smart when I'm probably not. But with that being said, um, can a lot of this stuff, can a lot of what's going on be really handled by diet? I mean, if you're really watching what you're putting into your mouth and the ability to control the food supply, because some foods, when you mentioned about psoriasis, I do know that there are studies out there that say certain autoimmune diseases can be positively impacted by a change in your diet, which
Hmm.
you're doing. And so I know there are other programs out there that push GLP-1s, and I want to kind of this reason why I want to get back on this. There are programs out there that have taken off as cottage industries. I'm not going to name the particular vendors out there, but there are several vendors that push GLP-1s as a means to a better life. And I want to kind of switch things a little bit to say, you got that, you got the manufacturer's direct consumer marketing and selling, right? So you've got all these entities trying to really push this publicly. What's what's a employer to do when they're trying to consider how do I balance this? But at the same time, you have some people that just simply believe that if you just stuck with better food, you wouldn't need drugs. So causation versus
Hmm.
treatment. I, there's a lot of that that's coming into my inbox these days. I'm having to cover this, and guidelines say everything that you say, but the more I talk to my clients, it's I honestly sometimes don't know what to tell them. So, what would you tell someone that's on the fence about covering and the balance and all this stuff going on?
I think that's a really good question, right? Because we know there's avenues outside of pharmacotherapy that work with regards to weight management. There's diet and exercise, right? I think that there's a lot of study with regards to the benefits associated with diet and exercise. What is concerning is that about 50 to 70% of patients that try diet and exercise ultimately stop the behavior changes, right, and regain the weight. I think that's a consideration. I also think that we need to be cognizant of some of the healthcare discrepancies associated with just access to more healthy food, right? And the relative expense associated with the difference between, less healthy, less nutrient rich foods versus healthy foods. So just the affordability considerations as well. It
Yeah,
may not be something that is truly an option for particular employees. So I think it's gotta be a multifaceted approach. It's really dependent on the the client, right? Their patient demographic, access to additional resources, the addition of wellness programs within their benefit design, dietitian access, exercise. I mean, we've heard of clients that are offering gym passes, for instance, as a way to
mhm.
potentially manage this population. But I do think it's not a one size fits all approach. There's been some additional research with regards to the utilization of GLP-1s because one of the concerns we have today is right now they're not cost effective. We think about the short term offset with regards to health care costs. We understand that it would take a significant discount in these particular medications for them to be cost effective. But if you have the optionality based on the research as it develops that potentially utilizing a GLP-1 for a year or two and then transitioning to an established wellness program after the fact may help to ensure long-term sustainable weight loss moving forward. So there's a lot of evolving data out there associated with this. So just making sure that you have the necessary information as an employer to make the most, educated decision, I think is really vital to ensuring that you're able to sustain a benefit like this.
I think that's the perfect comment, Tom, because a lot of employer groups are inundated with a lot of vendor requests for a meeting. Their product is better than uh, this guy's product's better than that guy's product, things of that nature. So what I'm hearing from you is doing your due diligence is not necessarily going to listen to one vendor. That includes me and Tom, everybody. we might provide a specific advice and opinion on specific things, but the more information you get from several different sources will help round out what might be the best thing for you. And in some cases, Tom, I know that we have some clients that we've had that have elected not to cover these medications or to discontinue coverage these medications because they're really guiding their members to go to something else, like either a no-go or really direct relationship. You talk a little bit about what the manufacturers are doing to provide access that doesn't necessarily impact the bank from an employer standpoint, where it becomes more of a member paying the full freight.
Yeah, I think that's a good point as we look to some of the opportunities that potentially exist within the marketplace to help drive down costs, right? And some of the immediate levers that we're able to pull is essentially cash programs, right? So direct to consumer optionality, right? So we've seen Lilly and Novo come to market with access to GLP-1s. Initially started with weight loss, right? So the weight loss, the Zepbound product, the Wegovy's respectively, were available through a direct-to-consumer, direct through the manufacturer process, where the cost of the medication was anywhere from $399 to $499. There was some slight differences specific to the Zepbound product, where it was actually a vial that was being offered rather than the self-injectable pen that is available through the traditional pharmacy benefit.
Mhm.
But there were some slight nuances associated with that, but it really gave the market an understanding of some of the optionality that exists today, where you want to offer a benefit, potentially make it a little bit more affordable. I think that is one of the options. The other one is the utilization of compounded products. So we've seen compounded products for semaglutide or tirzepatide that can range anywhere from $200 to $300 a month. And now the FDA has come out and basically said, look, that the shortages are over. Therefore, there should be no further need for the utilization of a compounded product. And what they've allowed for is these compounding pharmacies to utilize the remaining stock that they had prior to, right? But that's going on. So there's still compounded products available secondary to compounding pharmacies, just utilizing the bulk products that the FDA has given them allowance for. The other thing that we're seeing is some of the variations in dosing, which potentially skirts the FDA restriction with regards to compounding. So they'll add additional products to the
Mhm.
GLP-1. So B12, for instance, right,
Yeah.
is something that they'll do. Or what they'll do is offer a dose that's not FDA approved. So the micro dosing availability. So compounds as well is another option that's being utilized within the marketplace to drive down some of the costs associated with the utilization of GLP-1s. But I think it's important to really understand your contract when it comes to the utilization of these benefits outside of your traditional plan, just to ensure that the overall net cost of one of these medications is truly less than what it would look like through your pharmacy benefit.
I think that's a good. I think it's a good point. Is that when you're dealing with pharmacy contracting, um, of course, everything is usually based off the wholesale acquisition cost or an average wholesale price, and a lot of times you'll have a discount off one of those two numbers depending on your pharmacy contract. And then you have that becomes your ingredient cost by which you determine this is your plan pay, this is your member pay, and then there's a rebate on the back end. So when we're talking about your contracts for those of you that are listening, it's really looking at the full net cost. Some contracts may have pass through rebates of the actual product, and in some of these cases, the rebates on these products can be potentially 50, 55, 60% of the wholesale acquisition cost of these medications, but are fairly good. If you have a block underwriting type contract where you get a minimum rebate guarantee, you may or may not be getting the full value of the rebate associated with those individual GLP-1 medications like Ozempic or Wegovy or Rybelsus or Zepbound. So it's important, as Tom mentioned, is that what type of contract do you have? Is this the value? And then if you do some sort of outside the pharmacy benefit program, are there any restrictions? Sometimes a a program designed off benefit doesn't necessarily accumulate a member cost share in terms of the pharmacy and the wellness because it's not covered, excuse me, pharmacy and medical, because it's not covered under pharmacy, therefore it cannot accumulate under pharmacy, or it's not medical through a physician's office, therefore it's those copays are not accumulating to remember to have credit. So you need to know the puts and the takes when it comes to offering an off-label benefit. But I get you, Tom. I think these off-benefit options are a potential uh, way for employers to offer a benefit without necessarily offering a benefit and breaking the bank. And you also can potentially have some more control over the coaching aspect of it and the lifestyle changes to make sure people adhere to those types of changes which are needed for long term sustainability of weight loss and the potential to deprescribe from those GLP-1s once they hit a target weight, or if their diabetes is under control, potentially backing off to see is your A1C actually maintained with a better lifestyle at that point too. So I think there's a,
Right, having those resources to reinforce those
yep,
non-pharmaceutical behaviors moving forward. I think there's real value in that, and data is really kind of, enforcing that idea, right? The more recent publications of having these ancillary, offerings in place, right, to really change behavior. So we talked a little bit about, direct to consumer, right? One of the ways to potentially, reduce the overall economic impact associated with the GLP-1 utilization, right? I think there's other opportunities we look to the next 3 to 5 years that I feel hold some level of hope with regards to some additional downward pressure within the marketplace. I think that there's a lot of study right now of GLP-1s, and we've got some pending approvals that is my hope will offer something that will potentially alleviate some of the costs and concerns for clients and employees. There's some research in an oral alternative that right now I realize we have oral semaglutide within the marketplace today, right? But it's never been something that, based on the clients we manage, the population we manage, it's never been something that's really been up to par, or we've seen similar utilization as we've seen with the injectable GLP-1s. One of the reasons for that, there may be more adverse effects, GI side effects with the utilization of the oral semaglutide, right? You get a little bit potentially better A1C reduction with semaglutide, but you don't have the level of comparative weight loss with the injectable semaglutide. So I think that's impacted the uptake. There's also some dosing restrictions with regards to the oral version of semaglutide that may impact its utilization. But there's another agent that's likely to be approved in 2026 from Lilly that will offer another oral option. But the difference being it's a small molecule, right? So there's not the same dosing restrictions you see with the oral semaglutide because it's still a large molecule. It's a protein base, therefore it can be impacted by digestion, and that's why there's the additional considerations with dosing for a patient. This is a small molecule, so there won't have that level of restriction associated with or the consideration associated with utilizing it. Right, you can take it at any time. Um, the other thing that's important here is it came in with a weight loss at about 12%, so it's less than the semaglutide. So there is the potential with the manufacturer understanding that this isn't nearly the level of potency that we had hoped for. Maybe we come in at a discounted price secondary to the relative potency. So I think that's going to be an interesting development here to come, is the utilization of that oral agent, because we do know today that some of the limitations associated with utilization patterns when it comes to the GLP-1s is some level of needle phobia. So with this oral agent coming to market, right, that you don't have the same restrictions with regards to, or awareness needed with regards to dosing, does it increase the potential utilization of GLP-1s? And it may, right? Because now it's an oral agent. I don't have to inject. Maybe my compliance goes up. So even at a discounted price, you may see an increase in utilization, therefore an increase in cost. So I'm kind of arguing out of both sides of my mouth associated with that, but it is something to be aware of.
Um, we had that on a lot today, and I know that we talked a little bit about just kind of go back to something we mentioned earlier about indications, things that are coming up. So we talked a little bit about pipeline. We talked about a little bit about what's happening in the marketplace, direct consumer. We talked a little bit about some indications like Alzheimer's, you know, drug,
Pre-diabetes.
pre-diabetes, drug abuse, things of that nature. Um, we didn't really talk about this because it's already happened, but we did get an approval, a pretty big approval for MASH. We mentioned it in
Hmm.
passing, so that's something that we're going to be watching for in terms of the population. Apparently, there's a decent incidence of MASH that you can potentially access this medication, and so a lot of pharmacy benefit managers are in that in between space where you have all of these weight loss indications, and employer groups don't cover weight loss medications, but how do you potentially carve back in these expanded weight loss? That could potentially be a topic for another day, but I did want to see, Tom, if you could just kind of talk a little bit about that and the difficulties that it is when you have all these dual indications where a very specific class is excluded from a plan and design standpoint. But now all of a sudden, I got all these expanded indications. What do I do?
Right. It's really is very much a nuanced approach, right? So if we take MASH, for instance, GLP-1s, based on guideline recommendations, have been recommended off-label for a certain number of years, right? Well, was it 24 months ago? We had a product come to market specifically for MASH, uh,
Resdifra.
Resdifra, right? The interesting thing about Resdifra oral, it works differently than GLP-1s, but it was showing really good results with regards to the management of MASH, right? So fatty liver disease, the reduction or resolution of fibrosis within the liver associated with utilizing this medication. And there's a lot of interest around this medication, but it did come out at an annual price tag of about $50,000 per year. The semaglutide product that was recently approved for MASH, we understand that it's closer to that $20,000 per year range. So that may offer, right, a low cost alternative for the treatment of MASH that is showing similar results. I hate to say the same results because when it came to the study of semaglutide in MASH, the most recent study that was published was actually the study that is the only study so far that's actually shown a reduction in fibrosis associated with its utilization, right? So there's an additional study that needs to go on to ensure not only are we really kind of treating the preliminary, right, or the upfront fatty liver disease, but are we seeing a reversal of fibrosis, right, with the utilization of semaglutide? So more study to come with regards to that. But I do think that as a employer, right, I would want patients with MASH that for instance, I don't cover semaglutide for weight loss. I want them to potentially have access to semaglutide molecule maybe prior to Resdifra because of the price difference associated with that. So really having utilization management strategies in place that allow for clients to offer coverage of non-weight loss indications for these products for their population. I think there's real value in having those conversations. And I think this is a perfect example of why, right? If you have similar outcomes with an oral versus an injectable version, but at 20% of the cost, hey, I want to be able to explore potentially offering this to my population. And the way you do that is through utilization management strategies.
So that's been a lot. And everybody that's been listening to us has probably heard us interject GLP-1s at some point in the last year and a half or so as we've done the podcast. But this is not going away. GLP-1s are going to continue to be a hot commodity, right, in the pharmacy benefit space. And Tom mentioned 2027 for certain medications like with Boehringer Ingelheim, that it might be that time before we get some relief from a price point. Maybe we'll see what happens then. But I think there's a lot of salient points here. Is that when you're an employer group, appropriate is probably your best line of defense. Is there some creative solution that you want to look at from a wellness benefit or direct consumer type program that you want to leverage? That might be all well and good, but do your homework. Just making sure that it's the most appropriate, and how does it compare to your contract with your PBM today from a pharmacy benefit? And then ultimately balancing it out. Well, this is an immediate employee savings, and right now, the labor market's pretty tight. And do you want to offer this from a strategy for employee retention or employee recruitment? So this is going to be something that we're going to continually talk about for years to come. And there's going to be continued exploration, expanded indications that we've already talked about. And there's probably going to be more cottage industries come up that are designed to try to work through this to increase utilization. So we need to remain vigilant. Is this really truly improving patient outcomes? Is it addressing an unmet need? Is this utilization appropriate? Those are the questions we encourage our employer groups to ask, while desiring to be agile and potentially employ these innovative solutions to reduce their cost footprint, as it were. So, Tom, I think this is a good wrap up for this particular conversation today. It's not going to be the last that we're going to have this conversation on GLP-1s, but I think from our employers, I know they're appreciative of your clinical expertise in bringing in some of the clinical trial information and cost information. So I really appreciate you bringing that to bear.
You did a nice wrap up there, Bradley. Very eloquently said. I think for me, GLP-1s remain the next big thing. That's all I can say at this point.
And with that, from Farmland, I'm Bradley Nelson.
Tom Davies.
And we hope to see you the next time.